Hi, I'm Kristen Hodgden, an IVF mom, proud women's health advocate, and co-founder of Rescripted. Welcome to From First Period to Last Period, a science-backed health and wellness podcast dedicated to shining a light on all of the women's health topics that have long been considered taboo. From UTIs to endometriosis, we're amplifying women's needs and voices because we know there's so much more to the female experience than what happens at the doctor's office. With From First Period to Last Period, we're doing the legwork on your whole body so you can be the expert in you. Now let's dive in. Feminine hygiene is an essential yet often misunderstood aspect of women's health, affecting millions worldwide. From misconceptions about vaginal odor to the often overlooked journey through perimenopause, many women face these issues without adequate information or support. This needs to change. In this 4-episode mini-season of From First Period to Last Period, Dr. Shannon Klingman, an OBGYN and the inventor of Lumi, is here to rescript the conversation around female health and hygiene, because you deserve to feel confident and informed. Brought to you by Rescripted and Lumi, a revolutionary deodorant brand offering whole-body odor control that's seriously safe and outrageously effective for anywhere you have unwanted body odor. Hi, everyone, and welcome back to From First Period to Last Period. I'm your host, Kristen, and I'm here today with Dr. Caledonia Buckheit. Hi, Dr. Callie.
Hello.
Dr. Buckheit's been on the podcast before, so happy to have you back. Today, we're trying something a little bit different. We actually put up a question box on Instagram and got questions from the Rescripted community. The only prompt was you can ask an OBGYN anything that's on your mind. No topic is off limits. So exciting to see what people wrote in and happy to have you here to offer your advice and guidance.
Yeah, no, I love this prompt and I'm excited to hear what people have on their mind.
Yeah, absolutely. So for those of you who don't know Dr. Buckheit, she is an OBGYN practicing in Raleigh, North Carolina. So if you're in the area, hit her up.
Sorry. Accepting new patients.
Yes, exactly. And where can everyone find you on social before we get started?
I am on TikTok and Instagram at CallieBMD.
Awesome. So go give her a follow. So jumping right in, and there's not a ton of rhyme or reason to this, which I think is really interesting. And the point, like as women, we have so many questions all the time. I'm like almost 22 weeks pregnant and I feel like I've been Googling more than ever. And obviously when I was on my extremely long, arduous fertility journey, it was always like question after question. And you're getting answers from Dr. Google and you just wish you had like your own personal medical professional to answer all of your concerns. So the first question is, I ended up in the ER yesterday with the most horrendous abdominal pain. The cause, adenomyosis and cysts. Any advice?
Okay. Yeah. So I think as a resident and when I'm on call, people definitely end up in the ER with abdominal pain, and there may be a gynecologic origin to that, or it could be GI, could be GU. But in the realm of kind of acute pelvic pain, cysts are a super, super common cause of abdominal pain and often just rupture of physiologic cysts. So every single month, our brain is stimulating our ovary, getting ready for that next ovulation. Sometimes after ovulation, you can get the fluid-filled structure just grows and sticks around and then can rupture later on in the cycle. And that can be very painful. So that may have been kind of part of the picture for this individual. And then adenomyosis is an interesting topic. On ultrasound, which is probably what this patient had, you can see features that are suggestive of adenomyosis, but it's similar to endometriosis. It's a pathologic diagnosis. So you don't like officially know until you have like the uterus in a bucket and examined by a pathologist. So this is definitely a bad actor when it comes to like very painful, heavy periods, pelvic cramping symptoms, things like that. So I'm sorry that she had the cyst problem and the adenomyosis, but those are definitely issues that can lead to acute pelvic pain.
So how do you know, I guess as follow-up questions out of my curiosity, how do you know if your pelvic pain is serious enough that you should go to the ER?
Yeah, I think that pain that's unresponsive to conservative measures and some watchful waiting usually needs some evaluation. So if you're having cramping pelvic pain, you're having sharp abdominal pain, doing stretching, position changes, heating pad, taking Tylenol, taking Motrin, giving it a little bit of time, But if you're doing all those things and it's not getting better, then you probably need to get it checked out.
Yeah, absolutely. And is there treatment for either of these conditions?
Yeah. So if we're thinking about like the physiologic cysts, the cysts that can develop and then rupture, they're not like pathologic in the sense like there's nothing wrong with you or your body. Like this is a natural process, but it can lead to pain and unfortunate symptoms. The mainstay of treatment for recurrent ovarian cysts and cyst rupture is ovulation suppression. And so that would be with like combined hormonal birth control, like pills, patch, ring. Sometimes an IUD can be helpful, methods that will tamp down that stimulation of the ovary each month. As for adenomyosis, usually it's management of the menstrual symptoms and around periods. So treatments that get at heavy menstrual bleeding are good for adenomyosis. And then definitive management for adenomyosis is hysterectomy.
Okay. So if you're in your childbearing years, you're thinking about trying to conceive and you would GYN or right to a fertility specialist,
So I would definitely talk with your OBGYN about adenomyosis. Adenomyosis on its own shouldn't make it harder to get pregnant necessarily, but it can be tough in those months where you're trying to conceive, where you can't suppress or manage the bleeding with all of the tools in the toolbox, because some of those tools are contraception, which goes against the goal if you're trying to conceive. But there are strategies to use just during your menses to manage pain, symptoms, bleeding that you can talk to your OBGYN about so that hopefully you get pregnant that cycle. But if you don't and you get your period, you're not like totally out of luck for a symptom management standpoint.
Yeah. Awesome. So on to the next. This is a topic that I know a lot about personally, PCOS. So can you have PCOS without any symptoms, or I guess outward symptoms?
Polycystic ovarian syndrome, the way that most gynecologists are going to diagnose that is with something called the Rotterdam criteria. You have to have 2 out of 3 of oligomenorrhea, which just means infrequent periods, so like skipping cycles. So you would notice that, right? The other is polycystic ovaries on ultrasound, which you might not know, right? You might not have any symptoms related to that. And then the other is hyperandrogenism, which sometimes people do have outward symptoms of that: excess hair growth, oily skin, acne, cystic acne, things like that, but not always. Occasionally I'll get a patient who, for some reason, we end up doing a pelvic ultrasound, we find polycystic ovaries, and then we do labs. And she does actually have an elevated testosterone level. And maybe some of that is just being mitigated. And so she doesn't have a lot of outward symptoms of that elevated testosterone, but she would technically meet criteria for PCOS because she would have those 2 features. Does that make sense?
Yes, those are my 2 features. I have polycystic ovaries, or, it's so confusing because I always thought polycystic ovaries meant you had actual cysts, but really they're just follicles, right? Yeah. So a misnomer there in my opinion. but yeah, and then I have elevated androgens, but I don't have a ton of the outward symptoms other than I pretty much never get my period.
Because that's what I notice with PCOS. Like I diagnose PCOS most often when someone comes to me saying, hey, like I don't get a period every month. Like I'll go multiple months without getting a period. Why is that? And we start working that up and we find PCOS.
Yeah. But it's so interesting how it's such a spectrum, because I also have friends with PCOS who are very regular.
Mm-hmm. Yep.
So I don't know. It's like life's greatest mystery to me.
Yeah. At its core, PCOS is an ovulatory disorder. And that kind of gets into that. I say, 90 to 95% of people who are getting a regular predictable period are ovulating every month. But that means that 5 to 10% of people who are getting a regular period actually aren't releasing an egg each month. Right. And so some of those people might be those people who have the kind of like atypical, not that obvious PCOS.
Yeah, that's really interesting to me because I took a year off from fertility treatments quite recently, actually, and I was like tracking ovulation for the first time in years, and I got a positive ovulation using basal body temperature, but I was like, how do I even know if I release an egg? Like, I don't trust my body.
And sometimes you can get a bit of an LH peak, but it's not quite enough to release that egg. So I'll have patients, they'll be monitoring either basal body temperature, LH strips, what have you, to see if they get that LH surge. But then I'll have them come in a week later after we suspect they ovulated to check blood progesterone level, to check on, and did you in fact release an egg? Because sometimes you can get a little bit of a fake out there.
Yeah, that's really good advice to ask your OBGYN to check your levels after the fact,
Right.
just to confirm, because you could be trying to no avail.
Exactly. I know. I'm always trying to prevent that. I'm always like, okay, yes, you can try to conceive for 6 months to a year before doing fertility, but I'm like, that's assuming everything is totally normal. Let's make sure things are normal.
Exactly. So someone actually asked about the insulin resistant side of PCOS at Ozempic, which is like the hot topic of 2024, as I'm sure. So what is your take on Ozempic for PCOS as an alternative to metformin?
I think for patients, if they have diabetes, if they have obesity, if they have reasons where Ozempic is better for them than metformin, like by all means, it's going to work to address some of that insulin resistance. And because of it addressing the insulin resistance, it'll be helpful for PCOS. That's why metformin is helpful for PCOS. So I think that's why we're seeing all these pregnancies after Ozempic, because the insulin resistance that was inhibiting normal ovulation, as that gets better, there's less and less insulin resistance. Your ovaries are able to produce that dominant follicle and ovulate, then you can get pregnant, get cycle regularity back. I'm trying to get pregnant, that kind of thing.
Can you explain quickly how someone can tell if they're insulin resistant? Because I am not insulin resistant. And I almost I hate to say this, but wished I was, because I felt like that was something I could reverse in some way or work on.
About it, yeah.
Yeah, but yeah, so what are the labs to ask for?
So doing an A1C is the best. So hemoglobin A1C. And so what that's looking at is it's looking at glycosylation of your hemoglobin in your blood. And so it actually gives you an average of what your blood sugar was like over the previous 3 months. So it's a nice test. You don't have to check your blood sugars throughout 3 months, but you can and still get the benefit of that data just from a single blood drop. And so you can diagnose insulin resistance, or what we call pre-diabetes, on that. And then you can diagnose diabetes with a hemoglobin A1C as well. Other things that you can do, if you're getting fasting blood work done, say you're going to your primary care for fasting blood work, a fasting blood sugar is also helpful to determine insulin resistance or diabetes. And then there's also glucose tolerance tests, similar to the ones we do in pregnancy. You can also do those outside of pregnancy in certain cases to test as well.
Oh, okay. Interesting. Someone actually also asked, are these Ozempic pregnancies safe? Is there any research?
So I don't think we really know yet. For example, there's definitely going to be in the next year or so, these babies that are born and they were exposed to Ozempic during at least early pregnancy, right? Because people may not have known that they were pregnant and they continued to take the Ozempic. So I'm definitely
go off of it if you find out you're pregnant.
Supposed to go off of it if you find out you're pregnant. Yeah. We're going to have those patients who didn't know, right? Maybe they weren't getting a period anyway, right? They'd never, and they were on Ozempic, and then later on they find out they're pregnant. So I think we should have more data. Is there an increased risk of birth defects, preterm birth, blood pressure issues, blood sugar issues? I don't know at this point if there are adverse effects to pregnancies that are on or exposed to Ozempic. I'm not sure, but Ozempic certainly helps people get pregnant.
Amazing. Yeah. Awesome. So this is a good one. Why don't OBGYNs, and this is not speaking super generally, I guess this is this patient's experience, thyroid levels at the annual well visit?
At an annual exam? This is a good question. So I don't know, in the OBGYN world, it's not part, at least in my residency training and then in my current practice, when we're doing women labs or a wellness panel of blood work, you're correct. A thyroid is not part of that. Mm-hmm. And I don't know, I check a heck of a lot of TSH because I am checking it for symptoms. So if somebody has skin changes, hair changes, weight changes, menstrual cycle changes, things like that they're worried about, thyroid is something I will screen for no matter what, right? If there's any signs or symptoms that could point towards thyroid disorders. But I think in a completely asymptomatic patient, I don't believe that screening for thyroid disorders is standard.
Yeah. I'm assuming the question might come from, it feels like such low-hanging fruit. If that is something that's affecting your fertility, or that can be prevented.
Yeah, I think that if you have an indication, though, most providers would just go ahead and get it. If they're hey, I've been trying to get pregnant for a while, right? That's going to be one of the labs I order. So it is, in my world, I feel like it is low-hanging fruit. I check it all the time because I'm it would be a silly thing to miss, right?
Exactly. Yeah, it was 2020. and I had COVID not too long prior. So I'm like, oh, I must just have a long COVID. And I also have 18-month-old twins. So I'm probably just a tired mom. And my TSH was like through the roof. So big advocate of getting your TSH checked if you feel
low threshold to be like, hey, I don't feel right, or I have, any symptom, you name it, it could be associated with thyroid dysfunction.
a perfect example of how we like gaslight ourselves to, oh, I'm probably just tired.
I feel like a line I say all the time is like, two things can be true, right? You can be a tired mom of twins and you can have.
Exactly. Yeah. Someone just got diagnosed with chronic endometritis, which I think it's important to distinguish that between that and endometriosis, because I think people get those confused. So she's asking, how rare is this?
I don't know off the top of my head, like the percentage, but I don't know, maybe 1 in 100. It's rare, but it's not like incredibly rare.
What that is for everyone who might not know.
Yeah. So chronic endometritis is diagnosed on an endometrial biopsy. So this would be like either somebody had a DNC or they had the office Pipelle biopsy. And so you actually have a little piece of the endometrial lining that the pathologist looked at, and they're seeing signs of either overt infection or, more common with the chronic endometritis, is just signs of chronic inflammation. And so usually with that, you'll treat with a course of antibiotics to, if there is any underlying infection there, to make sure you've treated that, and then rebiopsying if indicated. It can be important in the fertility world, for sure. And then sometimes we'll see it when people just have irregular bleeding, abnormal bleeding. It can be a cause of that. Yeah, not incredibly common, but we do see it here and there.
Got it. And then the next question. So it's about endometriosis. So that's why I wanted to make that distinction. We actually have an entire mini season on endometriosis if anyone wants to go back and listen. But someone's asking, how can I go about getting diagnosed with endometriosis?
Yeah. So endometriosis it's a pathologic diagnosis. So you got to have tissue in order to officially diagnose endometriosis. The other way that endometriosis can sometimes be found or suspected is with ultrasound findings. But again, until you actually say you find a cyst on ultrasound that's characteristic in its appearance with an endometrioma, which is pathognomonic for endometriosis, technically until you take it out laparoscopically and send it to the pathologist, it's not official. Mm-hmm. But what I So for patients who have signs and symptoms that are concerning for endometriosis, talk to your OBGYN about it. And usually, at least my approach for these patients is taking a really good history, seeing what they've already tried for management. And basically, if you've already tried some kind of first line management for their symptoms and it's not working, doing a diagnostic laparoscopy, going in, actually looking with a camera, taking biopsies of anything that's suspicious, that's going to give you the most answers.
Yeah. It's crazy to me how the average is still 7 to 10 years to get diagnosed. People just think that painful, heavy periods are normal. And
I know.
Same thing goes if you feel like something's wrong.
Yes, I know. I'm always stop suffering. I'm anti-stop because it is amazing. I have people come and tell me, they're like, oh yeah, just ever since I've gotten my period, I just miss 4 days of school every month and I can't go to my sports activities. I can't do X or Y or Z. I soak through products overnight or whatever it is. I'm like, I don't need that.
Thankfully, I do think that obviously social media is a blessing and a curse sometimes, but I think younger people, Gen Z, are really starting to educate themselves more about their bodies and not taking any of that BS.
I think it's how I'm seeing it in the menopause world too. I'm seeing it in teens and people in their 20s, but then also in the menopause world, women being hey, I've been suffering and I just heard that wasn't maybe normal. I'm
yeah. Actually, the episode directly prior to this is all about perimenopause and menopause. And we're really excited to break into that in 2025 because my mother-in-law has been suffering for over a decade. And so many people think that hormone replacement therapy is the devil.
I know. I spent my day telling people it's not.
Yeah. So there's just so much misinformation and just lack of information. So it's definitely high time to talk about it all. Let's see. Oh, speaking of periods, can you please talk about PMDD? This person says, I'm affected by this and I don't really see people talking about it and it sucks.
Yeah. So premenstrual dysphoric disorder, for PMDD, this is a disorder that's characterized by severe mood symptoms that impact your ability to function in your day-to-day life that happens either during or right before your period and then gets better afterwards. So it's this very like predictable pattern. And that's what distinguishes it from other mood disorders that are more like pervasive, that might be like always have symptoms. Maybe they get a little bit worse during your period, but they're always there. That's probably not PMDD versus it's very predictable. Yeah, I just know that I'm going to have a bad week and a half out of every month right around my period and then it gets better. That's like classic PMDD. I think, again, like if you are noticing that pattern, bring it up. Mainstay of management for that is going to be like ovulation suppression, menstrual suppression, keeping hormones like a steady state, because it's believed that those mood symptoms are caused by the fluctuation, right? Because in a normal, healthy menstrual cycle, you've got like this high estrogen phase at the beginning of the cycle, and then the high progesterone phase at the second half of the cycle, and then that drops down. And it's that those fluctuations are what's precipitating the mood symptoms. So if you keep everything at a steady state, you're less likely to have those symptoms. So that's like usually first line management. And then there's also, you can use some of the SSRIs, SNRIs, things like that can also be helpful as well.
Got it. Yeah, that sounds really awful, like amplified PMS.
Yes. No, and it's about how like your quality of life and like your ability to like function. I think that's always like also a really good check to yourself. Hey, am I changing plans because my mood symptoms are so bad each part of the cycle? Am I, oh, I know not to plan a trip or make any plans around my period because I'm going to be in so much pain, right? That's like a good check for yourself. That's not normal to have to plan your life around things like that.
Agree, 100%. So the next couple of questions are all about pregnancy loss. I've been there. It sucks. I'm so sorry if you've experienced it. This person saying, I've had 3 pregnancy losses, all at 8 weeks due to no heartbeat. What are some possible causes of recurrent miscarriage that I should ask my doctor about?
So with 3 miscarriages, she should definitely have a recurrent pregnancy loss workup. The base of that, we do some lab testing, antiphospholipid antibody syndrome. So it's been like the autoimmune world. That can be a cause of recurrent pregnancy loss. Other things can be like structural problems in the uterus. So sometimes like if people have a septum or like polyp, fibroid, like problems within the cavity where you're not getting good implantation, things like that. So you want to investigate like the structure of where the pregnancy is trying to implant. Then the other is like genetic causes. So sometimes like mom and dad are like fine, normal. They have no reason to suspect they have anything genetically going on with either of them. But one of them might actually have a balanced translocation. So some of their chromosomal, like their genetic material and their chromosomes is actually switched over to a different chromosome. So when they're trying to pass on a copy, they don't pass on like the full normal complement of genetic information. And so then you get these recurrent miscarriages because when the genetics are trying to combine, you actually don't have like the right amount of information and it can't continue to develop. So that's like the very kind of basic early workup of recurrent pregnancy loss. That should be done or at least talked about with your provider if you've had 2 consecutive miscarriages or if you've had 3 at any point total. Yeah.
Definitely don't have to keep suffering. There are doctors that will get to the bottom of it.
Yeah. And we don't always find an obvious cause necessarily, but at a minimum, you've got to start that process, start that workup, see if we can find a reason for sure.
Absolutely. Another question about loss is any tips for preparing for pregnancy after 2 back-to-back losses?
So that's hard. I would say like talking with your provider, is there any suspicion as to why based on like how and when and what we know about those losses? Do we have any like understanding of potentially why it happened? Because obviously if we know that, then maybe there's things we could do differently this time around. Otherwise, if there's no apparent cause, I would just say general health and being things like taking your prenatal, exercising moderately, eating a healthy diet, minimizing stress, all those things as best you can. And then just really close follow-up with your OBGYN. Sometimes patients like that who have a history of, say, ectopic pregnancy or recurrent pregnancy loss, we may do some additional check-in visits depending on when the losses were in the past for added reassurance and closer monitoring.
Yeah, this hits really close to home for me right now because I'm pregnant after infertility, miscarriage, preterm labor, et cetera, et cetera. And I feel like I need to be like handled with care. It's so hard. And I like, the best advice I have, which is really, I'm not even practicing what I preach right now, but I'm just trying to set like really small goals. Okay, I just need to get to this appointment, or right now I just really want to get to 24 weeks and viability and then 28 weeks. But it's just so hard in the moment because when you're conditioned for bad news, it's so hard to think, oh, this pregnancy is different. It's going to work out this time. But as my therapist says, there's like productive worry, which is like taking your prenatal vitamins, going to your prenatal appointments. And then there's unproductive worry where it's like stripping you of the joy that you should be experiencing, which
Right.
I'm totally guilty of. But it's hard to be like in that celebratory mode after that.
Yeah. Hard to be in that celebratory mode as like an OBGYN. I feel like I like didn't enjoy either of my pregnancies because I just had like crippling anxiety the entire time because I had seen every possible bad outcome along the way. So it's just, really hard. It's really hard. I do think like one thing that I have found in my practice to be helpful is like with those patients, like a patient like you, like making a plan that's like reasonable, that's going to like be able to, okay, is it helpful that we check in every 2 weeks instead of every 4? Is it helpful that we do an extra ultrasound between this appointment and this? Like, like making a plan.
A massive weight off my shoulder. I started crying when my OB like actually recommended I go in every 2 weeks instead of every 4 because the last pregnancy, this is a completely different pregnancy. It's a singleton. I was pregnant with twins last time, but I literally went into a routine 26-week appointment and my cervix was non-existent and they were like, go straight to the hospital. So thankfully everything ended up working out. But when you have that trauma, no, I want to check at least until 24 weeks when they really can't do a lot of interventions at that time, like a cerclage or anything like that. But if it'll just give me peace of mind, like why not?
Yeah. And I think it's very reasonable to just be open about that with your provider. These are my fears. Some are rational, some are irrational. What do you think we can do as a plan to mitigate that and make it as less stressful as possible?
Exactly. And if your doctor's not hearing your concerns, maybe not the best fit to deliver your baby with them. I don't know.
Yeah, you need to trust your provider and feel like they're listening to you. I feel like I'm lucky where I live because I live in Raleigh, North Carolina. We have so many great OBGYN practices. I feel very strongly if a patient comes and sees me, it's not a good fit. That's okay. We've got great practices. You're going to find your people. I think not to look around until you find someone who's a good fit.
Absolutely.
Yeah.
So someone else, I feel so bad, wants to know about HG and pregnancy. As someone who's sick for like my entire first trimester, thankfully I didn't have HG, but that's rough.
So rough. It's so rough. I remember like my first pregnancy, I didn't really have any. And then my second, like I was just so sick, luckily only for a month and a half at the beginning. But like when I experienced that, I was like, oh my gosh, there are people who experience this for their entire pregnancy. Like just even as an OB/GYN, like I didn't really fully get it until I was there. It's just such a horrible feeling and a horrible disorder. So hyperemesis gravidarum is basically severe nausea and vomiting of pregnancy leading to like weight loss, nutritional deficiency, sometimes hospitalizations, a really tough condition. At least I feel like for most OB/GYNs, like we have a protocol that we go through escalating like the medication management and medical management of severe nausea, vomiting in pregnancy. It's a tough disorder to manage. What was her exact question about it? Just like any tips or?
How do I know if it's HG?
So I would say, so it depends on like gestational age, like duration of symptoms, like percent body weight loss, things like that. So definitely it's like unique to each person. But I would say like typical nausea and vomiting of pregnancy gets better with advancing gestational age. Like the vast majority of that will resolve by 10 to 14 weeks, usually does not result in weight loss. So that would be more like nausea and vomiting of pregnancy, which is like what I experienced and it sucks, but it like gets better and eventually goes right. The hyperemesis gravidarum like does not go away, does not get better. You're at a place where you're like actually really struggling to get in adequate nutrition and fluids. Yeah.
Yeah. Prayers then for everyone dealing with that. So lastly, I would like to ask, what would you rescript about the way people think about asking their OB/GYN questions at their appointments? Because I know a lot of people like get cold feet. I've forgotten my questions when I get there. Oh man, I wish I asked that. How would you rescript that whole way of thinking?
So one thing this is like slightly tangential, but one thing, as we were talking about, like making a plan, like shared decision making, a follow-up plan, things like that work specifically for you. Like a lot of that, if it's not hard for me to do those appointments, right? Like you might think, oh my gosh, like I'm asking this. It's such an unreasonable thing to ask. Like a lot of that, just know for us, it's easy. For me, it is easy to check heart tones in extra time, right? It is easy to do that extra visit for reassurance, things like that. So I would rescript that assumption that what you're asking is really a lot of extra work or out of not reasonable from your provider. That's one thing. And then asking questions in general, I think one challenge is the time constraints. So I think like you can ask and you should ask like whatever questions you have, but be open to having to come back another day to like fully delve into it. Be like, hey, I don't know if we have time for this today, but these are the questions I have. What do you think? And your provider will tell you like, hey, that's a super easy question. Here you go. Or I want to really go into that. Let's have you come back. Let's get labs. Let's like dive in.
I remember you saying that on the last episode we did together about the fertility consult.
Yeah.
You can have a kind of a separate meeting about that because it's really important and you want to get all your questions answered.
Exactly. But yeah, don't be afraid to ask. It's okay to ask. And usually you can make a plan for that question to make sure it gets answered and investigated appropriately.
Love it. Thank you so much, Dr. Buckheit. This was awesome. And I hope everyone got their questions answered. I think we'll be doing more of this in the future. So appreciate your time as always. Talk to you soon. Thank you.
If this podcast means something to you, be sure to hit follow or subscribe. This helps you because you'll never miss an episode, and it helps us because you'll never miss an episode. For science-backed women's health content that meets you exactly where you are, head to rescripted.com or follow us on social at Hello Rescripted.